Hello, everyone, and welcome back to the webinar series here from Unconnected. Thank you to you guys for joining us, and thank you to our esteemed panel of guests who have done the same. I'm going to ask them all to introduce themselves now. Today, we're going to be discussing healthcare and the digital divide in that space. So I'm going to kick things off with Dr. Lyle. Would you like to just sort of tell us a little bit about yourself and your background?
Yeah, my name's Lyle Berkowitz. I am a physician. I'm an internal medicine primary care physician who started out life as an undergrad as a biomedical engineer, which is a engineer who's interested in the life sciences, healthcare, etc. And always knew that I wanted to go to med school. Wound up finding this field of informatics or use of information technology in healthcare, and blended my career as a combination of taking care of patients as a primary care doctor at a large academic medical center named Northwestern Medicine in Chicago, being a system executive in the health system, focusing on technology and innovation and bringing new things in healthcare. And then the third leg of that stool is the entrepreneurial side. And I've been, as a physician, I've been involved in many digital health companies as an advisor, chief medical officer, operator, founder, and funder over the years, and have been particularly involved the past 7 or so years in the field of virtual care telehealth, which is bringing the online care to patients who often can't easily get into the doctor because of time, socioeconomic issues, or simply access. It's hard to get in. And so I've have been working with national medical groups who are online in trying to bring more access to everybody in the nation, because it's a huge issue. And currently I'm CEO of a company called KeyCare, which is a national medical group and organization that takes care of patients across the United States, and does so in coordination with health systems. We provide an additional workforce that helps support health systems managing their populations.
Fantastic. Thanks so much. Really excited to hear your thoughts. Dr. Waqas, do you want to go next and just sort of tell us a little bit about yourself?
Thanks, Oliver. My name is Dr. Waqas Ahmed. I am a physician also by profession, and I practice nephrology and hypertension management, which is a kidney disease, based in Jacksonville, Florida. I have worked in different parts of the world and I'm pretty familiar with different healthcare systems around the world. And for the last 8 years, I'm involved in healthcare innovation and started the company American Telephysicians, which is a multi-specialty virtual healthcare company providing physician services as well as technology solutions with more focus on the specialty care. On a personal level, I'm also involved in a lot of healthcare policy initiatives. I've been involved in policy making in the U.S. as well as international government sections. I'm also sit on the advisory boards for University of North Florida as well as healthcare systems. And been involved in some of the policy of the digital healthcare conferences in the United Nations as well. It's a pleasure to meet all of you, and looking forward for this great webinar series.
Brilliant. Thanks a lot. And finally, John Black, last but not least.
Yes. Yeah, thanks for having me. My name is John Black Kawuche. I am also trained as a medical doctor. I'm from Uganda, and that's where I trained medicine and been practicing at the Uganda Cancer Institute for about 10 years. So I have more experience in cancer care, but I'm not an oncologist. I'm more of a general physician. And instead of specializing in oncology, I went into medical informatics. So I did my master's in medical informatics in the Karolinska Institute in Sweden. And I also did my PhD in medical informatics in the Netherlands, the University of Amsterdam. And so since, sort of going away from the clinic or having one leg in the clinic and having another leg in research, I've been working on designing, implementing, and evaluating different digital health solutions that work for me as a physician, as a doctor in a low resource setting in a country like Uganda, and that has included really the entire spectrum of patient care, from solutions that are patient facing, like telephone advice services for cancer awareness and mental health, to think about electronic health record systems and what are the requirements for that, to understanding organization readiness to actually implement these solutions, and also thinking about evaluation of these solutions. Plus a few projects that have been involved in improving quality of care, for example, using artificial intelligence in automatic assessment of cervical images during cervical cancer screening. Again, trying to address pricing issues, the low-hanging fruit in an area like Uganda or low and middle-income countries in general.
Brilliant.
Happy to be here, and I'm looking forward to the discussion.
Fantastic. Thanks so much. So I think the first question I sort of like to ask, and I think it's always a really good place to start in these conversations, is about sort of identifying where the digital divide is, whether that's sort of globally or within individual countries. Because inherently, as someone from the outside, I think would say, if someone doesn't have access to the internet, how do you find who those people are? So I think if we just come to you first, Lyle, sort of going in the same order as before, how do you go about that? And what's the sort of biggest challenge for you in terms of meeting people where they are if they're not previously connected?
So, yeah, I was previously in a company that was a virtual care group that was more direct to consumer or work with insurance. Got referred patients via insurance. And the truth is, that's often not how patients find a doctor.
Mm-hmm.
And I'd say most of the time, it was really difficult, right? Because to reach out to patients, particularly in a lower socioeconomic status. I recall the best scenario I saw, were one, a Medicaid group that partnered with us. And what they did was they were very smart. They told all their patients, whenever you have a problem, here's a card, just call this number. Because they knew these patients were hard to reach. They often changed phones, didn't have easy access to email, etc. But they always knew, these patients, if they kept this one card, they kept this one phone number, they call this one phone number, and this group that took care of these Medicaid patients would always triage and figured out whether they'd send them to us for online care, send them to the hospital, etc. It made it easy so the patient didn't have to remember lots and lots of different things, and it kept it at a super easy way to do it. Another group benefited, so to speak, from giving patients bonus, saying, hey, if you use us for your minor things, we'll pay for your care. If you need more advanced care like emergency room, we'll help triage, and if you go, we'll pay for it fully. And that also increased utilization. My current company partners with health systems, and so a lot of patients, they look to their health systems as their first point of contact. And so that's actually where I believe we'll see a lot of motion, meaning they're going to contact their health system partners with us. So we take advantage of the fact that patients now, they are already thinking about their health system as the first point of care. We are an additional resource that they can utilize, even though the front door might be the health system, they can access our providers in a partnership as well. And so, in the end, you have to meet people where they are, where they think they're going to where you think they're going to go. They're not going to magically find you if you just put a link out on a website.
Yeah, sure. Well, Cass, what do you think about that? What's your experience been like in sort of all the various different markets that you've operated in before? Is it that real case of simplicity again?
Yes. I think the number one probably factor is because in a triangle you have a patient, then you have the doctors and the providers, and the third is the payers, who is paying for the service there. In countries where they're like more like Uganda or Southeast Asia, or like on those countries where there's not a universal, there's more a cash-based model, I would say, a private payer. Patients have to pay like self-pay. Of course, that's where we are seeing more trend or finding some of those platforms and finding online care. Whereas in the US and the more advanced country where it's mainly run by the payers, patients' journey typically start what's covered under their insurance. So then we see that in their insurance is kind of, they have this who's covered under the network, and then how they start looking there. That's one area. And second, I think is the center of universe is the doctor's-patient trust and relationship, and then word of mouth, because this is not just like a shopping. It's like kind of so a lot of the time when it comes to healthcare, patients also listens to some of their family members, and the word of mouth referral is the most important thing across the board, like across the universe. I would say that's a universal rule. In the developing countries, where now obviously for the digital health adoption, in the developing country, the issue is there's not many regulations for the government yet. Because if you have seen a doctor and now that doctor is utilizing a technology, or they're using a patient portal and all those things there, then obviously I think that's kind of leads to the adoption of this technology. So the fundamental deficiency in a lot of this international healthcare system is that the lack of implementation of the electronic medical record to begin with, because everything I think centered around the digital healthcare record. Whereas in the countries like US or now the European countries, they have made already a digital healthcare record, and now you're becoming a digital ecosystem. So I think the adoption comes from the physician and healthcare providers, and then of course then the people can find out more. I mean, it's no more different like whether is the nearest there's a nearest hospital to your location, but then if you in current age, if you cannot find them on the internet, or cannot find a portal for online appointments and all those things there, it's becoming challenging. I will be very surprised like how the internet adoption is even in the emerging countries or developing countries nation, because everyone has a cell phone, and they may not have iPhones, but they already have like a very affordable cell phone, affordable data plans, and I think that's where a lot social media is certainly playing a role to, and the community is playing a role to connect.
Brilliant. And John Black, what about you?
So I think there's, a few important differences between, a place like Uganda and where my colleagues, Wakas and Lyle, are working in the United States. Of course, there's connectivity. I know there is some rural areas in the United States that would also struggle with connectivity. But there is also how the healthcare system is organized and who is paying. So as Wakas has mentioned, in the places that I've worked in, I work in a public facility where everyone is entitled to getting healthcare services. They just walk in. We don't even need to know who they are, and they're supposed to get healthcare. They don't need to pay anything. And so the importance of demand in this case and supply, the dynamics of demand and supply are different. Because healthcare is funded by the government also supplies the digital health solutions if there's resources to support that. And patients don't have so much of a choice in, as long as they go to a public facility, they will use the solutions that are available there. But there's also a big private sector, and that is also growing. And in that case, people have choices on which solutions the private healthcare provider has, and that now is driven by marketing and competition and which one offers the best, the most convenient. Can I get services? Can I get my medicine delivered to me in the office, for example? And is that better than the other offer that another company is giving? So there's again, the normal market forces in the private sector, and then in the public sector, where you go and get healthcare essentially for free. It is funded by tax, then in that case, you use what is available, and the doctors will tell you this is the service that is available, and you consume that. I should say that there is not so much of these digital solutions. So, for example, having video conferencing to get telemedicine, that is not so much available, at least in the Ugandan experience. There was a bit of drive during COVID when healthcare providers were at home and they were using more basic like telephone calls and WhatsApp, for example.
And do you foresee a challenge there, John Black, in the sense that obviously the people who could really use telemedicine are those who are most isolated and those who are not going to be able to access private healthcare? How do you, even though it can be an expensive solution initially, work with governments to make sure that public healthcare can receive the same sort of contribution and technologies?
Yes, indeed, the people who need it the most are people who are isolated, who are in remote areas, people who are, much below the poverty line. And, for example, people in island areas where there's not a lot of infrastructure for them to access health services. If you are a government, as a public health entity, you sort of follow the 80-20 rule. You want to solve 80% of the problems with 20% of the resources, and that means that you have to first deal with the most pressing things. And unfortunately, digital health is looked at as the last resort. First, let's get vaccines. Let's get anti-malarial medicine in place. Let's first have, and then you begin to think about digital solutions, which also require a few other things. For example, you need to have connectivity. You need to have, if you're going to use the internet, you need to have broadband coverage in these places. People need to have access to the internet. They need to have devices, and they need to know how to use them. There is, digital literacy. So it's not enough just for you to put it in place if people are not going to consume it because they cannot meaningfully connect to it. And so what you end up doing is to first deal with the things that are more straightforward. If we can't get vaccines, maybe have a mobile clinic and bring screening services to you and provide vaccination services and provide primary health care services, then you do that. What I think needs to be done is that these basic healthcare services that are more feasible and more appropriate should be done, but there should also be more preparation for the future because things are changing quite rapidly. We are saying today people don't have access to broadband coverage, but that is not going to be the case in 3 years, in 5 years. We're having a lot of young people who are having access to the internet and they know how to use these solutions. So we should be preparing for that,
of course.
Even though now that might be not the case.
And of course, Lyle, I mean, I'm interested in, obviously, there's so many contrasts between someone like Uganda and the United States, but even in a country as developed as the US and other nations like it, and with the sort of unique healthcare system that the United States has, telecare clearly provides loads of exciting solutions. So I wonder if you could just speak to a few of those and where you see the major opportunities.
Well, the first opportunity is simply expanding access. The truth is, a lot of the patients who see us for virtual care would have gone to the emergency room or urgent care otherwise, and that would burden the system even more. And that's called, overutilization, inappropriate utilization, right? And a really bad experience for patients. So a lot of what I think is important to focus on is what I call the triple R threat that overwhelms our healthcare system: routine, repeatable, rules-based care. And that's going to apply in many ways, both in the US as well as anywhere. There's a lot of just basic stuff that needs to get done that's not getting done because patients have barriers to access. And so this decreases those barriers. And to what John Black said, by all means, phone can be an acceptable way to take care of folks as well, and the lowest common denominator for virtual care. Or we also can do asynchronous care as well as video-based care. But the first thing we do is sort of routine urgent care type stuff. I have an issue and I just need to talk to a doctor. Sometimes it's serious, and what we do is help triage a patient and help direct them to the right place. They may not realize you really have to go to the ER, or you don't have to go to the ER. You can just wait and see your regular doctor. But most of the time, we can take care of it over the phone or video.
Yeah, and Wakas,
Uh,
what other problems have you seen? Have you seen anything else, or do you think is it the same sort of the space you're looking at? It really is that sort of initial triage, and then dealing some of it over the phone, sending the stuff away that is more serious.
No, so I agree, Dr. Lyle. I think it's on the primary care or especially urgent care side. That's where telemedicine brings a lot of access and avoids unnecessary ER visits or the urgent care visits. We mainly focus on the specialty care, which is naturally more complicated because first of all, patients needs to have a continuation of care. They want to see, unlike urgent care, you can see different doctors for the various condition, but in specialty care is typically the continuation of care. Second, specialty care is also dependent on a lot of specialty diagnostic services. Let's say if you're seeing a cardiologist, they need to do an EKG, an echocardiogram. If you are seeing the nephrologist, and they're obviously working with dialysis companies or ultrasound and so on there. So with us, the specialty virtual healthcare, our focus has been to build an ecosystem approach where you not only bring the specialist physician, but you also have to interconnect them with all those ancillary service providers. So they can be interlinked, because looking from a patient journey, they will see a doctor, then they will go for a blood work, then they have to go for finding where to go for an ultrasound imaging, and then the prescription, and then it comes ongoing there. So our philosophy was to build a one-stop technology platform, which essentially interlinks the data coming from different healthcare electronic medical records. Then you bring specialists, and you also interlink them with blood work labs and radiology. And now with the remote patient monitoring actually has become a pretty significant tool in the virtual healthcare, because when these patients you're seeing for different conditions, whether it's heart failure or blood pressure or diabetes, monitoring them at home with the wearables as well as with their devices, blood pressure data coming to your, and then you can actually act on that data to avoid hospitalization. I give example, I am a blood pressure specialist, and then we utilize this technology, and we give these blood pressure devices which have a SIM card in it. Patients just take the readings, data automatically transmit in our system, and they have alerts. So when you can see when the blood pressure is running low or high, your medical assistant or nurse get notified, and then they coordinate with the physician to intervene. So you're now avoiding those unnecessary or I would say avoidable ER visits in the specialty care also.
I think it's really interesting. Certainly two of you, maybe all of you, mentioned AI in your introductions, and obviously there are loads of possibilities there that we've been working on for years, and that, especially in this space, are going to continue to grow. I think I just want to ask you, Wakas, quickly, and then we'll move on to the others, about especially when artificial intelligence at the moment is such an expensive thing to do, and obviously it will improve and that cost will come down, but at the moment it still remains so. How do we make sure that the same people that have been left behind in the past aren't left behind again, and that it isn't just really, well-off people who benefit from those renewed capabilities?
Absolutely. Thank you. I think that revolution is already there, because a lot of time when we see AI, same concepts as a co-doctor. And also, like for patient navigation, you will see more and more utilization for AI, especially on the wellness side, and the coaching side. There's a lot of kind of and the good thing about this whole AI, you don't have to reinvent the wheel. So there are already kind of those the technology like ChatGPT or Google's have their own. So it's about the integration now. So you integrating your solution with the already existing the AI engines, and then essentially customizing the workflow. And I'll give you an example. Like, so when you go to doctor's office now, you may have a bunch of when you see a new patient, especially in the hospital or in the clinic, you have like 100 pages to like 150 pages their medical history. So you're scanning, as a doctor, you're scanning what information and housing there. Utilizing this AI, essentially you upload in the system, and this essentially gives you exact summary. And then also, if any information which a specialist is looking for, let's say if a cardiologist is seeing the patient and they want to see, oh, what's the echocardiogram? So if you program in a way that, okay, now echocardiogram is missing, so you know what documents to look for or what is missing information. So you will kind of start seeing more and more AI for assisting on the clinical side or provider side for improving the workload. On the patient side, it's about now things, same simple tasks like, okay, my blood work shows some abnormal finding. What should I do? This is very classic. Like people get the blood work, especially where there's no continuation of care on the in the developing countries. Patients just go to lab and get a blood work. Now they essentially seek or send this lab report to someone they know in the medical. And I always say WhatsApp is the largest EMR system in the world, because being a physician, I see a lot of my friends, relatives send that information. But I think with this AI technology, they at least can now, okay, here's my report, and system will tell them, okay, maybe your diabetes uncontrolled. Now you need to see a specialist. So that regulatory part or the medical doctor side part is essentially will still be there, but you can see how it has minimized a lot of those gaps and the administrative as well as some of the delays. So as I see that there's a huge, tremendous transformation is going to happen over the next few years.
John Black, what opportunities do you see for less developed countries such as Uganda with using artificial intelligence, whether that's processing large amounts of data or something as sort of front-facing as a chatbot?
Yeah, I think there's tremendous potential because I mean there's a huge need, there's a huge gap for things as simple as patient education and awareness, which are very important prerequisites for patients to actually, get out of their homes, out of their chairs to go to seek health care services. This is something that sometimes seems a bit strange, but people need to, if you think about health seeking, they have to know, and they have to know that this is a problem and they can do something about it, that they start to seek for health services. And many of the healthcare challenges that we have in Uganda and many low resource settings is simply because people are not seeking care. I mean, we also don't have sufficient care services as we would want to have, but even those that are available are not utilized sufficiently. And that's because people need to be educated. People need to know that this thing that I'm seeing is actually a problem that I should go and seek care for. And it is not, we even have issues, for example, thinking this is witchcraft or this is managed like this, or we can try this other alternative. So patient awareness and education, there's a huge role for, and that is really just providing information. So there's potential there. And then, of course, if you don't have very specialist, trained specialists, you also have the potential to use AI and use these technologies to, work side by side with the, let's say, frontline health workers or non-specialists, so they can provide more advanced care. However, there is still lots of work to be done, and this is where it is important to be very intentional and be very deliberate. Kind of like how Unconnected is saying, we know there is all these fancy high-speed connections in other places, but we're also trying to get the connectivity to where it is needed.
Yeah. So
that intentionality has to be done for getting these solutions. Otherwise, we're still going to have a digital divide, but it's going to be on the services level. For example, there is very limited work that has been done in terms of languages in low resource settings. We now have a lot of excitement about ChatGPT and Copilot and BART and all these large language models. They have no clue. They have no idea what Luganda looks like. And this is how I have to communicate to my patients, but they don't speak my language. They don't speak Luganda. They don't speak Swahili, which is spoken by millions of people.
Yeah, that they're training on biases already.
I mean, they're trained on, and you find other places where there's even very few people speaking the language, and it's quite good there. But that is really an issue of inequality and imbalance that has to be intentionally addressed.
Absolutely.
There is some work that is being done, and I think there's also a realization that we're all we have to have fairness and equitable access for everyone, including people in low-resource settings. And so there's some intentionality and investment that is being done in resourcing these languages, for example. But there's still a lot of work that needs to be done. That's what I should mention.
Thank you. And I think just my sort of final question I always like to ask is just sort of asking you each sort of, if you in one sentence, there was one thing that you think would make a massive difference in your space, so in healthcare, to really bring those digital services to more people, what would it be? So I'm going to come to you first, Lyle. Sorry to put you on the spot. But if there was one thing that sort of governments and industry and enterprise could do together, what would it be?
You know, as you've heard me say a couple times, access is such an issue. And we have a lot of regulations, around that make it harder to get access in the US. So, I'd say I'm torn between regulations and financial incentives. I actually, though, in the end, while I don't have an MBA, I always boiled down my business experience to a single phrase, and that is the following. Incentives matter whether you think they do or not. And I think the more that we can align incentives to get what we want, the better. And that means understanding that how we pay doctors, and in some ways, how we incentivize or provide for care for patients. I would say that we are really good at being ingenious around figuring out technology, but we're often burdened by the fact that in the US, for example, we make more money if patients get sicker. And that's not a good incentive to have. And so the better we can figure out how to align incentives, how we pay health systems, physicians, et cetera, if we can align that well, everything else I think will fall into place. Regulations and technology, et cetera. That is not the hard part. We have more than enough technology to automate and delegate a lot of care. The biggest issue we have is how we pay for care, and the fact that patients, in many ways, aren't incentivized to be healthy. They should be, but the more we can think about incentives as a means to align physicians and patients, the better. So, long answer, but in one word, aligning incentives.
Amazing. Waqas, what about you?
No, completely agree with what Dr. Lyle said. That this is incentive has to be there. I think it's on one end, but however, the digitization is helping the government and payers to make those transformations, because change is not going to happen overnight, especially in the US. Unfortunately, I always say that we move from paper mass to digital mass first, and now they're realizing that essentially needs to be kind of unwind and correct that. However, on the payer side, because once the introduction of this electronic medical records and all this data they're getting, so there is a push now towards a value-based care model where it's more kind of incentivize the healthcare system providers to do those matrices, although the adoption has been very slow. And I think, as Dr. Lyle mentioned, because it's kind of more a hospital-focused model. You make more money on the procedure, surgeries, and all the thing there, and then that's kind of and it's also, unfortunately, because of some of the not having a universal coverage for people who don't have insurance, because on the other side, if you look at the healthcare system, they provide services to uninsured as well, and so that payment has to be kind of adjusted. I can certainly see, I think this is the way how things are now, as the cost alone is kind of, continue to grow. Those models, the value-based care incentives, especially like a CMMI models.
We've just got 1 minute, so I'm going to move to John Black so you can get a really quick bit in there. But thanks so much. Sorry to interrupt you. John Black.
Yeah, absolutely.
I just want to echo what Waqas mentioned of going from a paper maze to a digital maze, and that for me is a way to say that digital solutions are not going to solve inherent messes, and transition to digital doesn't take away the mess that was already there. So that has to be dealt with. However, my one sort of philosophy and idea about what needs to be done is more of a mindset. And that is user-centered design and empathy, and think about the user, whoever that user might be. It could be a patient, it could be a healthcare provider, it could be a nurse. Think about them and their challenges and their skills, and know that when you're designing a digital solution, you meet them at their point, where whether it is lack of motivation, skill set, design for them.
Brilliant. Well, thanks, John Black, and thank you to the rest of our esteemed panel for joining us today. I really hope that you have enjoyed our conversation and that you can join us next time. So thanks to you for listening, and see you on the next one.